Hello and welcome to our lecture about the autonomic nervous system, more specifically the sympathetic nervous system that is controlled by norepinephrine. Here's the outline. Just as a guide, we're going to be focusing mostly on the receptors involved in the sympathetic nervous system, the drugs that can stimulate the sympathetic nervous system, the drugs that can inhibit the sympathetic nervous system. And now, you may start feeling overwhelmed, and it can very quickly feel like you're just trying to memorize a bunch of drugs that you have no idea what they're being used for. But the important thing is that you come back to it every once in a while because it will be incorporated into a lot of your other organ modules. So this is the kind of topic that just keeps coming up in every module that you're going to take in medical school. All right, moving on to the sympathetic nervous system. Whenever you see the word sympathetic, I want you to think fight or flight. Just think of a scared animal that is being faced a very stressful situation and what that animal would need in order to take on that stress. Probably the way I like to think about it is it likes to reserve all the blood for the muscles and the brain and anything that can help the muscles or the brain, like the heart and lung. We have a couple different receptors found in the sympathetic nervous system, alpha 1, beta 1, and beta 2. Now, alpha 1, it's important because it allows your eyes to dilate. When your eyes dilate, that allows you to see at night. A lot of mammals evolved at night, and this helped them out a lot if there was a predator nearby. Another thing that the sympathetic nervous system controls is your blood. So it causes vasoconstriction, mostly vasoconstriction to your organs right around like your stomach, your liver, your kidneys, your bladder. You don't need these organs when you're scared. That's the last thing that you need to be doing is digesting food. You need to be focusing all of your blood onto the muscle. Another thing that you need is it causes sphincter constriction. Now, when I say sphincter constriction, I just mean like you don't really want to be using the bathroom when a predator is nearby. The next receptor is the beta 1 receptor. The beta 1 receptor is found mostly on the heart, and it's an important one because it causes the heart to beat faster and harder. And this just means that you get more blood to your brain and your muscles. Beta 2 receptor. Beta 2 receptor is a vasodilator. It relaxes. So it'll vasodilate the arteries that are around your muscles. And when you have that just means more blood can go to your muscles. It also has a relaxing effect on your bronchial area. In other words, it's your trachea, your lungs, and it allows more oxygen to get to your lungs and into your blood. And that just means more oxygen for your muscles and your brain in a stressful situation. Now, as for the sympathetic receptors, the way I learn them is using the KISS mnemonic. KISS mnemonic helps me learn the corresponding G protein that is attached to every sympathetic receptor. For example, alpha 1 is attached to the GQ protein, and I could just follow through with alpha 2 and beta 1 and beta 2 just through the mnemonic QISS for KISS. I'm just going down. It's important for us to have a general idea about what each G protein does. For example, GQ has the effect of increasing calcium through the IP3 system. And here it is. Here's GQ. And it would just cause a stimulation of IP3, which then causes vesicles to release calcium. And calcium is very important for vesicle release. So it's very good for contracting smooth muscles and releasing vesicles. Another two receptors is going to be the GS and the GI. Pretty easy. GS stimulates the cyclic AMP, so you would get an increase in cyclic AMP, and GI would cause a decrease in cyclic AMP. And this can cause varying effects within your body. One exception that we do need to be aware of is in the heart. In the heart, you actually have a GS, not a GQ, but this GS actually activates a calcium channel, and this calcium channel will cause the heart to contract stronger and faster. Alpha 1 is found in the smooth muscles throughout your body, especially the vasculature. So if you were to stimulate alpha 1, it would cause an increase in calcium and contraction, and you would actually expect an increase in blood pressure. You would actually also find them in the dilators of your eyes, and that would cause mydriasis, which is just opening up of the eyes. And you can find them in the sphincters in your GI and genitourinary, and you'll see the sphincter contraction with the sympathetic response. The next one that we need to know about is alpha 2. Alpha 2 is actually a negative feedback mechanism. It actually inhibits the sympathetic nervous system. And here's how that works. Whenever your sympathetic nerves release norepinephrine into the synapse, a little bit of norepinephrine will go back and it'll affect the alpha 2. And alpha 2 will have a negative feedback response. So you don't waste all your epinephrine with just the slightest stimulation. Next one we're going to talk about is going to be beta 1. Beta 1 is found mostly in the heart, and this is very important. It's because when you get to beta blockers that are cardioselective or non-cardioselective, since beta 1 is only found in the heart, it's very good for blood pressure medication to just target beta 1 to reduce the heart rate and the blood pressure. Somewhere else that you may find beta 1 is going to be in the kidneys. It actually releases renin in the kidneys, and renin is a very important mechanism in which your body uses to increase its blood pressure. Next receptor is going to be beta 2. Beta 2 has a vasodilatory effect if it's found in the muscles, so you would actually get more blood flow into your muscles when stimulated. It also has a bronchodilatory effect. It relaxes the muscles inside of your airway and it allows more oxygen to get into your lungs and your blood through this mechanism. Finally, the last one that you need to know is going to be beta 3. It's not very much tested, but beta 3 is mostly just for metabolism. When you stimulate the sympathetic nervous system, you would expect a slight increase in metabolism, in other words, burning more fat to provide your body with energy. All right, moving on to a direct sympathomimetic. When I say a sympathomimetic, I mean a drug that mimics the sympathetic nervous system, like norepinephrine in the sympathetic nervous system. And by direct, I mean that it binds directly on to a sympathetic receptor. Now, the first drug of choice is going to be the norepinephrine. Norepinephrine binds mostly onto alpha-1 receptor, and this can cause some vasoconstriction. Vasoconstriction would then cause an increase in blood pressure. That's why we can often use it for shock, but it just needs to be given as a continuous IV. Something that you need to understand is that it can cause reflex bradycardia. Brady means slow and cardia means heart, because it stimulates alpha 1 a lot more than it really stimulates beta 1. It doesn't really do much for beta receptors. And here's how the reflex bradycardia would work. You would get vasoconstriction of the arteries, which would cause an increase in blood pressure. Your carotid is going to detect the increase in blood pressure through baroreceptors, and it'll send a signal to your heart telling it to slow down. And that's how you get the reflex bradycardia. So whenever you see norepinephrine, you'll see the heart rate actually drops right over here, rather than increase as you would see as you'll see later with epinephrine. Moving on to epinephrine. Epinephrine is like the jack of all trades. It'll trigger every single sympathetic receptor in your body pretty much. It'll increase your blood pressure, of course, through alpha 1. It'll cause some bronchodilatory effects through beta 2, and it'll increase your heart rate through beta 1. And this is great because when you're in shock, you need an increase in blood pressure. When you're having heart failure, it's great to have a beta 1 to increase your heart rate. And if you're going through anaphylaxis, it's great to have beta 2. So it helps you open up your throat so you don't choke. Now, something you need to know about epinephrine is epinephrine reversal. Here's how epinephrine reversal would work. Now, we know that epinephrine will affect both alpha 1 and beta 2. We know that alpha 1 would increase your blood pressure. We know that beta 2 has a lot of relaxatory effects and it'll cause a decrease in blood pressure. Now, hypothetically speaking, if a patient is taking an alpha blocker, what would you expect epinephrine to do? Well, it's blocking the effects of the alpha, so you don't really get an increase in blood pressure. Epinephrine would actually give you a decrease in blood pressure only. And this decrease in blood pressure is the exact opposite effect that you would expect from epinephrine. Moving on to dobutamine. To me, dobutamine sounds like do beta 1. And beta 1, of course, we should know by now, is main receptor for stimulating heart rate and heart contractility. And when would you want that? That would probably be very helpful for heart failure. Moving on to isoproterenol. Isoproterenol is not very often used in the clinical settings, or at least I haven't heard of it being used. But it is used in step 1 questions, and it usually comes in hypothetical form questions. It's important for you just to know that it stimulates both beta 1 and beta 2 receptors. So you would expect the effects on the heart rate, an increase in heart rate, but not really much of an increase in blood pressure. Now, why wouldn't you get an increase in blood pressure? It's because the beta 2 would contradict the increase in heart rate. Beta 2 causes vasodilatory effects, while this causes an increase in heart rate. They kind of counteract each other, so you don't get much of an increase in blood pressure. Moving on to phenylephrine, it's got the ephrin in its name because it comes from the ephedra plant. Now, in ancient Chinese medicine, they used the ephedra plant in tea to help people with viral infections or stuffy noses. And what it does is it stimulates the alpha-1 receptor, which causes vasoconstriction of the capillaries that are causing all of the swelling inside of your nose, and it allows it to be less leaky. That's a great treatment for stuffy nose. With modern medicine, we've taken it one step further with pseudoephedrine, which not only has the vasoconstriction effects of phenylephrine with alpha-1, but it also has a bronchodilatory effect of beta-2. So not only do you get less leaky noses, but you also get increased airway breathing. Some patients may choose to use it to make meth. And some of you Breaking Bad fans may know that pseudoephedrine was used in the first season to make methamphetamine using the Birch reduction. Now, albuterol is probably the most important drug in the pulmonary module, and you'll know that it stimulates the beta-2 receptor. So what you would expect is an increase in the diameter of your airways or bronchodilation, and that's very important for patients suffering from asthma and COPD. All right, moving on to the indirect sympathomimetics. Just a little bit of background. Here's your sympathetic nervous system releasing the norepinephrine. Once it's made the norepinephrine, it's going to release it into the synaptic cleft. You could imagine that after it's released, it's going to not only affect the receptors over here, but it can actually kind of build up in the synaptic cleft. And we need a way to kind of reuse it and bring it back. And that's what this reuptake over here does. Now, if you block its reuptake, you would imagine that it would get a significant buildup, and you would get a much stronger sympathetic nervous system response. That's exactly what cocaine does. It blocks norepinephrine reuptake and causes it to build up, and you get a strong sympathetic nervous system response. You would expect a lot of vasoconstriction through stimulation of alpha-1, and this can be used to stop bleeding, especially in the cases of facial surgery. Another effect that cocaine has is that it can also block sodium channels, and that's very similar to local anesthetics like lidocaine. And this is also pretty useful for facial surgery. Something that you need to know is that, hypothetically speaking, I'm not sure if there's anything published on it, but if you can imagine a buildup in norepinephrine, and you're taking a beta blocker, you would see a lot of the effects of the sympathetic nervous system then moving towards alpha-1 without getting an increased heart rate. So you would get an increase in bodily resistance through vasoconstriction, but your heart can't speed up to compensate. And this can make an MI or a heart attack much worse. Moving on to amphetamines. Amphetamine is also known as Adderall. The gimmick for this one is that it can cross the blood-brain barrier. So it's very useful for treating stuff like ADHD, narcolepsy, and obesity. And this obesity is just appetite suppression. And it works by preventing norepinephrine reuptake, just like cocaine does, but it can actually also stimulate norepinephrine release. So you get a very, very strong effect releasing norepinephrine to the synaptic cleft and preventing it from going back up through reuptake. Moving on to ephedrine. Ephedrine comes from an ancient Chinese medicine, ephedra. So it can be used to just stimulate norepinephrine. And this is very useful for nasal congestion and urinary incontinence and hypotension. Something that you need to know about ephedrine is that it does not cross the blood-brain barrier, so you can't really use it for ADHD or narcolepsy or the appetite suppression as you can for amphetamine. Now, for alpha-2 agonists, we need to learn a little bit about alpha 2. Alpha 2 is a receptor that's often found in the presynaptic nerve of the sympathetic nervous system, and it's attached to a GI protein. And the GI protein would actually inhibit the sympathetic nervous system through inhibiting norepinephrine release. You would get less norepinephrine release. And here's how your body would use it. You would usually release norepinephrine to the synaptic cleft, and this buildup of norepinephrine would go back and trigger the alpha 2. Alpha 2 would then work as a negative feedback response and prevent you from releasing any further norepinephrine. And this helps you conserve a little bit. The most important drug that you need to know about in this class is going to be clonidine. Clonidine, there's also some other ones like guanfacine and brimonidine, but I think clonidine is the most often used in questions on USMLE. What you need to know is that it's going to stimulate the alpha 2, and alpha 2 it will then inhibit the sympathetic nervous system. This is very useful for hypertensive urgency, especially with renal patients, patients who have bad kidneys. You're going to learn in cardio and renal that a lot of the blood pressure medication that we give are actually bad for the kidneys. So when you have someone who has high blood pressure and it's so urgent that it's actually damaging all of their organs, you want to give them a drug that reduces their blood pressure without further damaging their kidneys. Another use for it is going to be ADHD and Tourette's. It has a calming effect on the brain. Moving on to methyl-dopa. This is a very useful drug for hypertension or hypertensive urgency in a pregnant woman. It doesn't really affect the fetus as much, and that's really good for preserving the fetus's kidneys. All right, let's talk about alpha blockers. They're divided into non-selective group and selective group. The non-selective group is very useful for serious situations of hypertensive crises. One of those situations is going to be a pheochromocytoma. This is just simply put a tumor of your adrenal gland that can cause an overload of sympathetic nervous system response. You would expect a high heart rate, high blood pressure, increased sweating, everything that you would expect from a sympathetic nervous system. The drug of choice is going to be phenoxybenzamine. Phenoxybenzamine is an irreversible blocker. It's very important that you know that it is irreversible because the tumor is going to be there for a while. You want to keep this on them especially while they're in surgery. When you're cutting out the tumor, it's going to actually release extra amount of norepinephrine and epinephrine, and that's going to actually make everything a lot worse. So it comes in handy to use phenoxybenzamine in the pre-op situation. Another one that you might be interested in using, which is more reversible, is phentolamine. Phentolamine is pretty much the same effect as phenoxybenzamine, but it is reversible, and it can be used in cases of hypertensive crises. Moving on to alpha-1 blockers. Alpha-1 blockers are more specific. They end in osin most of the time, and they're very often used for benign prostatic hyperplasia. This is just an enlargement of the prostate that often occur with age, and through blocking alpha-1, you could actually expect a decrease in size. As a side effect, you would actually also experience a decrease in blood pressure through blocking of alpha-1 in your vasculature. Something that you need to know is that tamsulosin has a low and it only works down low. So it's actually more specific for the prostate but does not have the hypotensive effects that the other ones may have. All right, moving on to mirtazapine. Mirtazapine is a great antidepressant. It's used to treat depression through the blockage of alpha-2. When you block alpha-2, you would actually experience an increase in sympathetic nervous system because the alpha-2 that's usually there to inhibit the sympathetic nervous system is no longer there, and you would get a lot more norepinephrine effect. And that just gives you a little bit a feeling of more energy, and that's great for patients who are depressed. The added effect of mirtazapine is that it causes an increase in appetite. So I like to think of Taz as in the Tasmanian devil that's found in Looney Tunes, how he likes to eat a lot. Likewise, your patients will also experience an increase in appetite and may also increase in cholesterol. All right, let's see how they may choose to ask questions to test your understanding of the autonomic nervous system. Let's just do a quick review. Phenylephrine over here. Phenylephrine, we know that it stimulates mostly alpha 1, and this causes an increase in blood pressure. If you give someone who is taking phenylephrine an alpha blocker, you would just pretty much prevent the effects of increase in blood pressure. If this is someone's blood pressure and then you give them phenylephrine, it goes up like this and then goes back down. If you give them an alpha blocker beforehand, you don't get that increase in blood pressure. It just pretty much levels off. Now, epinephrine, you would actually see a reversal. All right, we know that if you give someone epinephrine, you would actually see an increase in blood pressure. However, what happens if you do an alpha blockage? What happens if you block the alpha 1 effect and you don't get that increase in blood pressure? Here's what's going to happen is that epinephrine is going to go and only affect beta 1 and beta 2. Beta 1 causing an increase in heart rate, so you would see the patient's heart rate go up, as shown right over here. But beta 2 would cause a dilation of arteries, and this actually causes a drop in blood pressure. And this is what we call epinephrine reversal. Instead of getting an increase in blood pressure, you actually get a decrease in blood pressure. And it's very important that you understand this concept. All right, moving on to beta blockers. Beta blockers are very important in the medical field. They tend to end in LOL. If they end in OLOL, that means that they're going to be only beta receptors. They're going to target beta 1 or beta 2 only. If they have an A or an O before the LOL, then you can expect them to also target alpha as well, so that you would get a little bit of the alpha blocking effect, which reduces blood pressure. Now, the most common mechanism that we like to aim for is a beta 1 blockage. When you get a beta 1 blockage, you would get a decrease in heart rate through inhibition of the SA node and the AV node found in the heart. Now, this is very useful for stuff like angina, which is just another term for chest pain, MI, supraventricular tachycardia, hypertension, or heart failure. It helps you reduce the heart rate, and this helps reduce the oxygen demand of the heart. And when you do this, you actually reduce the damage that is done to the heart, and you can decrease mortality. So it's very important for keeping patients alive longer. Moving on to the adverse effects of beta blockers, the first one that we're going to go over is going to be erectile dysfunction. Erectile dysfunction can often negatively affect the patient's compliance. Patients are going to be sticking to taking the pill every day if they get these kinds of sexual side effects. The next one is going to be bradycardia. Of course, that's the whole point of beta blockers. That's the effect that we want. But it can actually go out of hand and actually cause an AV block. It can pretty much slow the heart too much, and this can make heart failure worse. Another effect that you would expect is sedation. You would get sleepy due to your heart it's not working as fast, and you're pretty much inhibiting your sympathetic nervous system, so you're not as awake and alert. The most important side effect that is often tested is going to be the asthma and COPD exacerbation. And this is specific for beta blockers that have a blocking effect of beta 2. And that can cause constriction of your airways and increase difficulty in breathing. All right, let's talk about more specific beta blockers. There's just too many to list, so I just go for some shortcuts in memorization. All the beta blockers that start from A through M, I just remember AIM for the heart, and that helps me know that they are cardioselective agents. Cardioselective agents is good for asthmatic patients because you don't get the beta 2 blockage, which can cause an impeding of airway flow. Examples of beta blockers in this category are going to be atenolol, esmolol, metoprolol, and all of them are going to start with A through M. Now, non-cardioselective agents, they're going to be the rest of them. They're pretty much bad for asthmatics, and they're going to start from N through Z. Examples of those are going to be nadolol, pindolol, propanolol, timolol. Finally, the last group that we need to know about are the beta and alpha mixed blockers. There are only really two of these, and it's going to be carvedilol and labetalol. If you remember earlier when I said if they end in A or an I instead of an O, so O is only beta, A and I means that they're going to be mixed beta and alpha. And another way that I learned these is Don't mix what you carve in the lab. This just helps me learn carvedilol and labetalol. And these not only have the effects of blocking beta 1, but they also block alpha 1. So you would get a decrease in vascular resistance and blood pressure, as well as a reduction in heart rate. Well, that's pretty much it for the sympathetic nervous system drugs. Right now, it might feel like a lot of memorization, and it really is because you don't know the context that these drugs play in each of the modules as of now. But it's important for you just right now to focus on the receptors, what G protein they're attached to, and what drugs that affect these receptors. Just try to memorize those, and then as you go through the organ modules in the future, they're all going to fall into place, and it'll make a lot more sense. Keep coming back to this lecture as you're going through your organ modules, and you'll realize that you understand a lot more of it as you go through medical school. Good luck.